I'm Dwayne Schultes. Welcome to this Vital Health podcast. Today I'm joined by William Smith, Director of Life Sciences at the Pioneer Institute. Bill, it's great to see you at your home. Thank you.
My pleasure. Thank you for having me back.
It's always nice to talk to you, Bill. Last time we discussed the ins and outs in the world of quality. Today we're talking about something else, something that's much more of a la mode, I think, something that's really going on today. Yesterday, you presented results of your preprint study on 340B, comparing 340B hospitals to non-340B hospitals. Can you start off by just telling us what exactly is a 340B program, aside from a typical government alphabet soup?
Yeah, it goes back to 1992 when it was enacted. The reason they created the program was to correct something that they did a couple years earlier when they enacted the Medicaid best price law.
Okay.
So pharma companies had been given deep discounts on a voluntary basis to hospitals that treated a lot of low-income patients and clinics. And the problem is the Medicaid best price law enacted in 1990 would have required that those prices go to all 50 state Medicaid programs. And of course, the clinics in particular were concerned that prices were going to rise for them because the prices are going to ripple through all 50 state Medicaid programs. And prices indeed started rising. And so the clinics went to the Congress and said, you got to pass a drug discount law for us.
On the surface, that sounds just fine, right? I mean, it sounds like that should be, it's benevolent, it's charitable, it's everything we should be doing, right, Bill? Isn't that the point?
In theory, yes, in theory, especially for the clinics, because the clinics are, in my view, some of the good actors in this system. But around 2000, at least according to the data, around 2000, hospitals started to figure out that they could arbitrage the discounts. What does that mean? Arbitrage, buy low and sell high. So if they could bring in patients that had good commercial insurance or Medicare, they could buy an oncology drug, say at a 60% discount, say a $100,000 drug they could buy for $40,000. And then they could bill Medicare or they could bill the commercial insurer $100,000 and they could pocket a $60,000 spread. That really changed the program enormously because hospitals had an incentive to bring in wealthier patients with better insurance. They started opening up satellite offices in wealthy towns and neighborhoods. And I see that in Massachusetts with Mass General. They've gone into Concord and Wellesley and all sorts of affluent towns. The program really got off track by some hospitals, not all, but some.
So you had this inkling, people have had this inkling that there's been some abuse and some arbitrage of drugs as this program was obviously where there's an opportunity. There's been a suspicion that things were going on. Why were you approached to do this study? What was the methodology and what were you asked to do?
Well, the study was instigated by Cancer Care, which is a patient advocacy organization for cancer patients. And they had been getting anecdotal reports from their patients that they went into 340B hospitals and they couldn't get charity care or the hospital wouldn't accept Medicaid. And that's kind of a violation of the spirit of this statute. The whole point of this statute was to give more resources to these safety net hospitals and clinics so that they could treat more low-income patients. We got anecdotal reports that this wasn't happening. And so we decided, well, let's do a study. We have enormous database that we get from the RAND Corporation. We buy it, actually, and it has got details on every hospital in the country. And so we decided to do a comparison between 340B hospitals and non-340B hospitals to see how much charity care, unreimbursed care, how many Medicaid patients they were treating, what kind of job were they doing as far as treating low-income patients. The most dramatic finding was that 340B hospitals give out less charity care. This is counterintuitive because not only does 340B probably provide $40 or $50 billion in revenue to 340B hospitals. As nonprofits, they get tax breaks, which the Senate Help Committee estimated as $28 billion. In addition, they get plussed up Medicare payments under DISH. This was a dramatic finding that they're providing less charity care.
So no matter which way you looked, I mean, you could always assume that, okay, maybe this is an error, maybe this is just a flip of a coin, but if the coin always turns up heads, I suppose after 50 flips or 40 flips, you start going, what the heck's going on?
Well, given the resources that are provided to 340B hospitals, one would think, as far as charity care and unreimbursed care and treating the uninsured, they'd be dramatically higher than for-profit hospitals.
Does this imply then that the charity hospitals that are being covered and getting tax breaks are actually providing less uninsured care, which is sort of the whole point of the program?
Yes, it does imply that. And there are exceptions. I don't want to paint with a broad brush with hospitals because, Cook County Hospital, for example, which is in inner city Chicago, gives out 11% of their operating revenue in charity care. That's 5 times the national average. So there are some hospitals that are doing the right thing, and clinics generally do the right thing. What we've discovered is that large academic medical centers are the worst.
Really?
Yes. I mean, whenever I go into a state to testify, and we testified in 20 states last year, we look at the hospitals and which ones give the largest amount of charity care. And inevitably, the biggest hospital is a University of Michigan, Northwestern, an academic medical center in Massachusetts. That's MGH. Their charity care numbers are paltry, especially when they're making $2-3 billion in revenue. And they like to say we give X amount of charity care, but it's a percent of operating revenue, which is the relevant data point. They give a minuscule amount of as far as their operating revenue.
Was there a wide dispersion? Did you see a large variance between hospitals? I mean, because the data you have in this preprint is point estimates. So, it's averages. Are you seeing huge variances? Are you seeing widespreads?
Yes. So, for example, let me use the Massachusetts example because I'm familiar with that. Boston.
I'm shocked, Bill. I'm shocked.
Boston Medical Center, which is an urban hospital in downtown Boston, gives about twice the national average in charity care, and they've been doing that consistently. So it's about 4% of operating revenue goes to charity care. Mass General Hospital, which has a comparable revenue base, gives about 0.31% in charity care.
You also found that 340B hospitals serve a higher percentage of Medicaid patients. Your Cook County example, which makes a lot of sense. A lot of them are inner city and dealing with an impoverished population. How much of the skew here could also just be because of the nature of the health of the patient class?
It is true that 340B hospitals generally treat more Medicaid patients. And that's not surprising because the original statute had eligibility. You had to have 11.75% of your patient base as Medicaid, and then you become eligible for these 340B discounts. And it's an interesting story. The reason they picked 11.75% is that's somewhat arbitrary. Ted Kennedy needed Republican support. And the 11.75 threshold to become eligible for 340B captured both the University of Utah for Orrin Hatch, and it captured the University of Virginia for Tom Bliley, who was prominent then on the health committee. So the threshold to join the program was you had to treat a certain number of Medicaid patients.
Well, let me dig into that then, because if you've got 19.6% versus 17.7%, and the threshold's 11.75%, okay, I'm thinking if you're in Cook County or you're in South Boston, that 11% should that 19 should probably trend a heck of a lot higher, should it not?
Yeah, it should. And these numbers are comparable. Non-340B hospitals and 340B.
Yeah, 2%.
It should be much higher for 340B hospitals, in my view.
So a cynic might say, well, okay, the threshold's 11%. Okay, we're at 19%. That seems pretty good. I mean, I could see you're obviously going to be called in to testify in Congress, I'm sure. And I could see cynical lines of questioning coming from Elizabeth Warren or some of the folks here from Massachusetts and Connecticut, where we are now. The hospitals have broad political support. I mean, how would you respond to them saying, well, these numbers don't seem that bad. It's only 2% difference. And isn't that okay?
You're getting close to $80 billion in subsidies to treat lower income patients. You should have dramatically higher Medicaid numbers than for-profit hospitals.
So what do you think's happening? Crystal ball here. What do you think's going on?
Well, we've got anecdotal reports that Medicaid patients are being turned away because the reimbursements are so low by all hospitals, not just 340B hospitals. And Cancer Care alerted us to this fact, and it's one of the reasons we did the study.
One of the only states that's actually pushed for transparency ironically, given all the challenges around Medicaid that's come out recently, is Minnesota. The recent transparency report that was published by the hospital director general at the state of Minnesota Health Department, they found that hospitals generated $1.34 billion in net revenue in 2024, which was an almost doubling of the previous year. I mean, that's a 112% increase annually, which seems extraordinary to me.
Yes.
Why do you think that is? Is this just being used as a cash cow for the hospitals?
For some hospitals, it's seen as a profit center and exclusively as a profit center, and they open up. There's this story about Bon Secours Hospital in Richmond that the New York Times broke, where here's an inner city hospital that's treating a lot of African American patients, poor, and they're a 340B hospital. So what they did is they ripped out the ICU, they ripped out the emergency room, and they stripped the hospital that was in an inner city neighborhood down to nothing. And then they opened satellite offices in wealthy Richmond neighborhoods so that they could get 340B patients to come in and they could arbitrage the discounts. So these kind of abuses are happening. It's not happening at every hospital. I think, there are Cook counties and Boston medical centers that are doing the right thing, but it's happening.
Your preprint study, there's a direct quote here. You highlight that the 340B program has a misalignment between program intent and outcomes and support the need for greater transparency, standardized eligibility criteria, and minimum charity care requirements. How do you propose to fix that?
Reform should happen slowly on this program because 340B is a major safety net program for a lot of people. And the first step you could do without harming anybody, harming any hospitals that are doing the right thing, would be transparency. Hospitals need to report exactly how much revenue they're taking in from 340B and exactly where they're spending it. And I think if that kind of data was available, politicians would start to pay attention.
So if you wanted to get transparency, what would be the first steps? What would this require? A bill through Congress? Could this be, my concern with this administration, we're just going to get an executive order and then that goes away, the next person comes in. What would need to happen? Are we talking legislation? Are we talking reform?
The states can actually require transparency because they regulate nonprofits.
As they did in Minnesota.
And I testified in the House and Senate in Indiana, and I'm not going to take credit for this law, but after my testimony, they enacted a law that will be in effect for next year where 340B hospitals are going to report their revenue and what they're spending it on. So it's possible to get transparency. And the reason, again, I like transparency is it's not a cut in the program. It's just we need to shame some of these hospitals that are not doing the right thing.
Part of the problem with transparency is a lot of these hospitals are nonprofit, and they were for-profit, but then they've converted to nonprofits. If we want to open this up and look at some of the issues we're having now around PBMs and the Inflation Reduction Act and a lot of these things, you're seeing enormous vertical integration. You have hospitals buying medical practices. They're starting to buy their own pharmaceutical products and in-license their own pharmaceutical products, branded generics and biosimilars. Is that going to be possible to crack open, or is that ship sailed? Or is everything just going to stay nonprofit and there's not going to be any transparency on the balance sheet side?
I'm hoping we'll get transparency on the balance sheet side. And one thing I've recommended to state legislators is if they require transparency, force hospitals to deposit all 340B revenues into a separate account that can be audited so that expenditures, you're going to see what they're spending the money on. Right now, the 340B revenue goes into the general operating. And, who knows? It's executive salaries or it's a new wing or an MRI machine. You just don't know. And right now, we need to create some mechanism where it can be audited.
Now, according to a report I really like that ran in the Motley Fool a few years ago, if you look at the top 5 employers in California, okay, 3 of them are hospital or university hospital systems. It's UCLA, UCLA Med Center, and UC Davis. Now, the other 2 are literally Disney and the U.S. Navy. Is a politician going to be willing to go into the buzzsaw against all of those votes?
No, it's very hard. Although with some exceptions, like, for example, when I talk to black caucuses of state legislators around the country, they're indignant that the resources in this program are being targeted towards wealthy people by some hospitals. So, there are exceptions, but generally, I wanted to tell this story. My son was the legislative director on Capitol Hill for an Ohio congressman who will go unnamed. And I bent my son's ear about 340B, saying this program needs reform. I talked to him for an hour. And at the end, he's like, Dad, we have the Cleveland Clinic. Are you kidding?
Yeah.
I can't do anything about this.
Yeah. So is that why essentially they've turned a blind eye to this? Because it's votes. It's just cynically, it's votes.
Yes. And inevitably, especially with state legislators, the largest employer in the district is a hospital. So it's politically, it's very difficult to make reform.
I was speaking to a hospital manager, again, that shall remain nameless, and he outright admitted, we'll probably just expand 340B to make it up.
Yep. North Carolina treasurer also did an interesting report where he pointed out that in the state employee plan, they were marking up oncology drugs to 5 times the acquisition cost. And this was costing the taxpayers of North Carolina a lot. So transparency is starting to catch on a little bit. There's the Indiana law, there's Minnesota, there's North Carolina. And I'm hoping that when these numbers come out, people are going to be embarrassed.
Isn't part of the challenge here that for the last 24 years, since Medicare Part D, essentially there was a hidden incentive that covered a lot of these costs through the catastrophic phase. When it went to catastrophic phase, the government was essentially picking up a lot of these flow-throughs.
Yes.
And now with IRA and benefit redesign, we've gone from the catastrophic phase being covered 80% by the government to now insurers are 60% on the hook. Is there just a lot of unintended consequences here and a lot of ham-fisted policy that's now bumping up against economic reality?
Yeah, the 340B, I always say it was a sloppily written statute. And I read the legislative history. They didn't anticipate that hospitals would start arbitraging the discounts and start wanting to treat more wealthy patients with good insurance rather than low-income patients. They just didn't anticipate that, and they should have.
So between the Inflation Reduction Act, MFN, 340B, we're seeing companies that have traditionally been small molecule oncology leaders moving into asset classes that avoid the elderly. I mean, we're just seeing a general pattern here.
Yeah.
Everyone is behaving rationally in an irrational fashion, if that makes sense.
Yeah.
Everyone is following the incentives very well, but yet we've created a bunch of perverse incentives in the system.
Well, the thing about the IRA price controls is it's a little bit of a crapshoot. If your company's drug is not picked, well, you skate. And with 340B, if you have a marketable product, it's going to be discounted and sold to hospitals. And it's an enormous program now. 1 in 4 branded prescriptions are 340B prescriptions.
What's going to happen if we continue to force down and disincentivize the Medicare program? What is the end result of that? Where does this end up?
We're looking at a nuclear winter for biopharma. The pricing pressures are so enormous. MFN, IRA, 340B. It's just I don't know how you make a living anymore.
It's 2026. We're going to start getting the biologics negotiated. The hospitals make ASP. They make a revenue on the back end of that. If a drug's getting priced down, they're going to lose ASP. I mean, are we just seeing that 340B is seen as the economic get-out-of-jail-free card now?
It is. It is. For many hospitals, financially, it's whack-a-mole, right? Prices of the MRI machines goes up, and you need to make up for it somewhere else. And 340B is always the cash cow, the profit center where you can go and get more patients that have good insurance and buy the drugs at a deep discount, particularly oncology drugs and rheumatology drugs. I mean, 40% of prescriptions in 340B are oncology.
54% of all research has been oncology, at least small molecule oncology, but we just published a preprint before ASCO, and we've seen a 35% reduction there, Bill. I mean, we're disincentivizing that whole value chain.
Yes, undoubtedly.
Essentially what you've got is you've created incentives to try and sell more oncology products, but there's going to be fewer and fewer oncology products that are either A, not going to be discounted due to price controls being put in through MFN or IRA, or B, they're just not going to be there, or C, they're going to be theranostics or drug antibody conjugates or something like that that are going to be very difficult to play and cover.
You mentioned this earlier, but what 340B is causing in the oncology world is enormous consolidation because hospitals are going out into the suburbs and buying up oncology practices because they want to capture those patients. And those practices currently can't compete with 340B because they're buying the drugs at a much higher price, and the margin they keep is much smaller. So they're happy to sell their practice to a 340B hospital. And this is not good for the oncologists.
We did a podcast with the former head of the AMA. She runs an independent series of oncology clinics in the West, in New Mexico and Arizona. And she is saying that without that ASP, without that drug margin, they're going to be underwater on a lot of their treatment already because they don't have that arbitrage that you're saying.
Yep.
It's sort of what's happened with the capital requirements that have concerned with community banks that have occurred where, the community banks are forced to essentially sell themselves to one of the big three U.S. banks, and we're losing community banks. And we're going to see a similar type of action occur with the small independent oncology units that are often the ones doing a lot of the clinical trials.
Yes, it's undoubtedly true.
So where do you see things going right now? I mean, we've just had the OMB, Office of Management and Budget proposal by Vought, where they're talking about putting oversight into research by politicians. We're getting rid of academic oversight. We've got IRA. We've mentioned MFN. We've seen rampant abuse in 340B. Where do you see things going, Bill?
Well, the IRA is going to impact 340B enormously, and I don't think the hospitals have seen what's coming because once you have 150 or 200 of the top selling drugs that are price controlled and the government is pushing down their list prices by 50% or more, the ability of hospitals to arbitrage the discounts is going to be enormously cut. It's just inevitable.
So what happens then?
Well, hospitals are going to probably ask for a bailout.
So what's the next steps in the report, Bill? How can people access it?
Well, we're hoping it's going to be published in the Journal of Managed Care, and if that's the case, we'll send it everywhere. But it's on a pre-publication server now, and people can access the report. We're going to put these materials from the presentation we did yesterday. That will be available online on the Pioneer website. Well,
Bill, it's a great report. I congratulate you. It's excellent. I always like to see other people doing good work.
Thank you.
I always like reading other people's work, Bill. And again, congratulations, and I wish you all success.
Thank you.
The executive producer of the Vital Health Podcast is Dwayne Schultes. Editing by Caden Drake. The Vital Health Podcast is a production of Vital Transformation LLC, copyright 2026.